Aman sir, you may start, please. Sir, unmute करिए.
So should I start, sir?
Yes, sir, please, sir.
Thank you
Start
so much,
करिए.
sir. Thank you. So today we have Dr. Vinila with us, along with Dr. Saurabh Jain, and we have two lead discussants, Dr. Barnali Bhattacharya and Dr. Rashmi Kapoor. So we have a touch of glamour today in our case discussion, and we hope to have a very. I believe we will definitely have a good academic discussion here. Dr. Barnali and Dr. Rashmi Kapoor are both astute clinicians. So I will straight away request Dr. Vinila to please start with the presentation.
Yes, sir. Can you see my slides, sir, now?
Yes, you are audible. The slides are visible.
Okay, sir. A very good evening to all my respected seniors and colleagues. I am Vinila. I am currently pursuing my fellowship under Dr. Kalapnavar, sir, in SS Institute of Medical Sciences in Davangere. Today, I will be presenting a case of a 5.5-year-old girl. She's a resident of Davangere, and her informants are her mother and father, both of whom give good, reliable history. She came to us with chief complaints of easy fatigability of 1 month and paleness of hands and face of 15 days. History of presenting illness. She comes with complaints of easy fatigability of 1 month when the parents noticed a gradual decline in her general activity. She began to tire easily during her routine activities, and her mother also reports that earlier she used to play outdoors for 1 to 2 hours every evening, but now she prefers to sit quietly or lie down just after 15 to 20 minutes of play. She also has been reluctant to participate in physical activities like running or dancing, which she previously enjoyed. She avoids climbing stairs and is seen resting more often. Mother also noticed paleness over the face and palms for the last 15 days, which is insidious in onset and progressive in nature. Her mother reports that this is not the first episode. The child has had multiple such similar episodes in the last year, every time presented with marked pallor and fatigue, for which she received blood transfusions. The child reportedly shows improvement in energy and activity levels for a few days or weeks post transfusion, but the symptoms gradually recur. She has no history of nasal bleeds or blood and sputum or vomitus, no black colored stools, no history of prolonged bleeding, no history of petechiae or spontaneous bleeds, no history of pica or passing worms in stools, no history of urgency of stools, diarrhea or greasy stools, no history of jaundice or abdominal distension, no history of joint pain, swelling, skin rash or photosensitivity, no history of fever, cough, weight loss, or night sweats, no history of repeated respiratory illness or sinus symptoms, no history of edema, puffiness of face, or decreased urine output, and no history of altered sensorium or seizures, and no history of no similar illness in the family. She has a past history tracing back to 1 year, so I have divided every admission. So the first admission was at 1.5 months of age, where the child presented with complaints of fever, cough, and hurried breathing. For these complaints, child was admitted and child received nebulization and oxygen via nasal prongs. Child was discharged after 3 days of the hospital stay. Discharge advice was to give oral iron supplements. From that 2 months of age until child turned 4 years, child had multiple OPD consultations but never had an admission requirement. All these consults were for cough and fever of 6 to 7 episodes per year. The cough was usually dry type, sometimes associated with hurried breathing, and usually improved by day 4 to 5 of illness. Child had no interval symptoms. For these complaints, child has received nebulizations on few episodes, oral antibiotics along with other symptomatic treatment. The next admission was when the child was 4.5 years of age. This was the first episode of generalized weakness and reduced appetite. The consultant physician has observed pallor, for which she was further evaluated for anemia. Hemoglobin was 3.6 grams per deciliter, for which child was advised admission and PRBC transfusion was given. At this admission, child was again advised for oral iron therapy along with some nutritional advice. 1 month later, when the child came back for a review, the parents have told that the child was transiently better for a week, but then the complaints persisted. Child also had complaints of fever of 2 days at this review. Blood work was done. Bone marrow aspiration was also done. A chest X-ray was also done at this point. The parents were told that the child had some pneumonia, for which they were advised admission. IV antibiotics were given for 5 days, along with a PRBC transfusion, and the child was again discharged with oral iron. 2 months later, child had continued complaints where growth was observed to be normal. She was again advised for blood transfusion, but also received IV iron infusion at this point. She was discharged with oral hematinics and was asked to come back every month for iron infusions. They were also advised for further evaluation, but the attenders took a month later to come. When she came back, HP was again dropping. So they had run a couple of scans and tests on her, where she was again transfused with blood and IV iron infusions. So 2 months after this, child had taken another consultation outside, where child had complaints of pallor and weakness. At this point, child also had breathlessness, but there was no history of fever, cough, or wheezing. Child had one complaint of swelling over the chest region, which gradually increased in size. And this increase in size was for the last 2 months, and hence they approached the doctor. But this was told to be a benign lesion and to just reassured about it. Child was also advised for genetic testing and other blood workup. A chest X-ray was done at this point as well. Child was discharged with oral folic acid supplements and other vitamins. From 5 years to the current age of 5.5 years, child was on a follow-up. She received 2 more blood transfusions and was referred here for further management. Family history: she's a second born to a 3rd degree consanguineous marriage. There's no family history of blood transfusions or transfusion dependent conditions. There's no history of TB contact. Birth history: antenatal, natal, and postnatal are fairly uneventful. She's developmentally normal with an average scholastic performance. She last received vaccination at 1.5 years of age, and no additional vaccines were taken. She's non-vegetarian by diet, but her overall, she has a 20% calorie deficit and a 10% protein deficit. They belong to an upper lower class according to modified Kuppuswamy classification, and there's no significant environment or contact history. I would summarize the history as she's a 5-year, 6-month-old girl, 2nd order, born to a 3rd degree consanguineous marriage, partially immunized for age, and developmentally normal, with history of repeated blood transfusions for anemia of the last 1 year, and has now come again with complaints of progressive pallor and easy fatigability. So you're muted, sir.
Thank you, Dr. Vanila. I think she has presented a very comprehensive history. But I'm sure you would have questions. If so, I will first invite Dr. Rashmi Kapoor, madam. If you have, you wish to seek any clarifications or you wish to give any opinion on whatever we have discussed till now.
Yeah, Vanila,
Yes.
very nice history. But could you go back to no history? Your
Yes.
slide to no history?
Yes, ma'am.
No history of? Yeah. So there is no, you said there is no history of respiratory illness. So did she not complain of cough and respiratory distress on the first examination, on the first admission? Or
No,
have I heard it wrong?
no,
No,
ma'am.
she did not come with, as you had said, that at 1.5 months of age, she came with, she was admitted with complaints of fever, cough, and breathlessness. So was it not there?
No, yes, ma'am. At 1.5
Yeah.
months of age, she did have complaints of rapid
Okay.
breathing.
Okay, right. And another thing, is there a history of any joint? Yeah, you have said. So any history of loose motions, pain in abdomen, and any preference to any kind of diet, rice or wheat? Did she have any? Did she suggest?
No
No,
history
no
of
history complaining to abdomen, right?
no, ma'am. No,
Oh,
ma'am.
okay. And would like to just see the growth velocity of the child, like if she was growing well and the velocity was good.
Yes, ma'am.
Velocity was
According
okay.
to the parents' history, the growth was fine, ma'am.
Okay. And never did she have any sign of respiratory system involvement, like no breathlessness. And you attribute the breathlessness that she had on any of these occasions to anemia.
Yes, ma'am. From the
Okay.
parents' view, yes, ma'am.
Okay. Okay. That's all from my side.
Thank you so much, ma'am. Now I will request Dr. Banali, ma'am, to please present her thoughts.
You're muted.
You,
You're muted, Barnari.
Okay,
You're
so
muted. Yeah.
Vanilla, the
Yes.
first admission at 1.5 months, when you said, was cough fever, and the discharge card you said was given iron. We rarely ever give iron at 1.5 months. So, was there anything to point that there was anemia at that stage?
They were told that child would be requiring iron at discharge. Yes, ma'am.
Yeah,
They were
because at
told
one
that.
and a half months, generally we don't supplement with iron. So that's one thought that came to me. And of course, you've done an excellent history of negating a whole lot of problems, including connective tissue, including renal, that there could be no malabsorption because the nutrition is not so bad. But in all your presentations, there is the cough, there is the breathlessness, there is once told pneumonia on x-ray. So there is something happening up there, I would think. And obviously there is some ongoing bleeding, right? That's why she is getting these repeated transfusions. So, do you think that this breathlessness that she's having is only because of anemia? Because we have on X-ray query pneumonia, we haven't seen the films as yet, though. Your thoughts?
It could be, ma'am, but from the parents' point of view, at this stage of history, I would still be thinking because of no other symptoms that they are worried about, I would still be attributing this to pneumonia at this point, ma'am.
Okay, fair enough.
so we have had a good discussion. Dr. Banali, if you wish to add something else also.
No, I just saw that in her entire thing of a lot of negatives, the only thing besides the blood transfusion and the hematinics that's coming up is, x-rays done and pneumonia said, breathless. So I wouldn't, sometimes there is breathlessness without cough. So I would keep, I'm kind of thinking, what was there in that thing that the x-ray of pneumonia. So my mind is kind of going towards, probably zeroing down to something, but let's just see what more we can hear.
So we have looked at the chat box also. There are more comments than questions here. I understand with this kind of a history, we know the child has anemia, no doubt about that. The point is whether it is not being produced, whether it is being lost. That's the issue. And if it is being lost, where? Whether it is in lungs or some other system, that's our question. The thing that it is most likely lungs is, the biggest pointer to that is that it is being discussed on a pulmonology forum. Otherwise, on history, Vanilla has tried to make every attempt to say that, okay, there is no respiratory involvement, no distress. But when you say pneumonia, I mean, and once or twice you have written hurried breathing, fast breathing.
Yes.
That means there is something there. And I believe if it's a part, the question here is, was it a part of CHF or a part of primarily lung involvement? You could look at other indirect corroborative evidence. I mean, if a child has CHF, maybe he would have some puffiness, some swellings also, in addition to fast breathing. A child to have distress because of CHF and not to have any puffiness, edema, whatever. I know it's a small child, but now it's 5 years. So if not pedal edema, periorbital, something should be said. Though, what is your take on this? As we would say, do you think it is CHF or is it primarily lung involvement? Vanilla.
So, but on history, they do not point anything towards features of CCF.
Okay, fine. That's fair, because you know this history better than any of us. We are being guided and groping onto whatever you are offering us. But and now, if we say, okay, lungs is where we more likely to think of it as. Now the second question comes up. There is another way to look at it. When you have a disease, and it starts so early, almost in infancy it has started, and with time it is growing up. The first thought, if you think of in terms of approach, either it is congenital or it is something genetic. And more so, I think you said it's a consanguineous marriage.
Yes.
So with those things, the thing come to my mind is, started too early with a consanguineous marriage. Probably it is something congenital, genetic, which is boiling up rather than something acquired here. It could be congenital, lung congenital, cardiac congenital, hemolytic, any congenital or genetic thing which could be coming up. So one point that I wish to seek in your history is that, are these episodes discrete episodes, or is it that in between the child is well? It'll help us differentiate between things like maybe a cardiac issue, where you can have persistence. There will be exacerbation in between, but persistence throughout. Or it could be very discrete, which can happen in bleeds in lungs. So is it discrete episodes in between the child completely well, or is it exacerbations which are but otherwise also the child has been having something and he's never normal?
So, from the history of 2 months to 4 years, I had mentioned about cough complaints along with fever a few times. During that period, intervally, child had absolutely no symptoms between each each episode. But after 4.5 years since the first admission of severe anemia, child has an ongoing illness. Child is not completely all right, as child has been frequenting the hospital almost every month. And even at every month visit, they have always told that she was transiently better, maybe only for 5 days to a week, but then the symptoms came back.
This is what I exactly wish to ask. You are saying that in between also the child is not well.
Yes, sir.
Okay. So that's it. So I think let's have a look at her differentials that she has thought of, and then we will see what we can. Okay, Dr. Vanilla, you can proceed here with your differentials.
Yes. So with this history of recurrent pneumonia, I have divided the probable causes into hematologic. Hematologically, we divide it further into causes of impaired cell production. That includes the spectrum of inherited bone marrow failure syndromes and nutritional deficiencies, which cause impaired red cell synthesis. The points for these would be severe anemia requiring transfusions, but the pointers against the first IBMFS or the inherited bone marrow syndromes is the age of onset. And the thing that is against the nutritional deficiencies is the requirement of repeated transfusions every monthly, which is not very common. The next spectrum would be causes that would include increased cell destruction that could be classified into hemoglobinopathies, enzymopathies, or membranopathies. All of these present with chronic anemia and requiring repeated transfusions, and usually improve completely in between the episodes. But the pointers against this are this child has no complaints of jaundice. The next set I would go ahead to look for is the ongoing blood losses. A few of my differentials here are AV malformations that could be in the gut, lung, or the skin. The second closest that we would think of in a child is celiac disease, and the next would be pulmonary hemorrhages. All the points that go in favor are recurrent anemia with asymptomatic periods in between. Taking the history back from 1.5 months of age. And the points against would be no bleeding symptoms, no bleeds of, no melena, skin bleeds, hemoptysis, or hematochezia. The next, what I put in my differentials is iron refractory iron deficiency anemia. This is usually presents as refractory to IV iron as well, requiring transfusions very occasionally. But there's no bleeding or there's no hemolysis that is suggestive in the history. The points against this, as this is one of a very rare, so we should always think about rare in the end, and this always requires a genetic confirmation. Other systemic and autoimmune causes of SLE and vasculitis should also be kept in mind because of the gender and with the history of chronic anemia. But there's no systemic involvement, there's no rash, joint symptoms, or bleeding.
Thank you, Dr. Vanilla. I think as flagged in the chat box, my question to you would be, this is more like an approach that the way we were discussing. We would want to know from you that given the scenario, which is more likely based on your history. Okay. So which one of these is more likely based on your history?
So most likely, I would still be thinking of iron refractory iron deficiency anemia and ongoing blood losses.
So I'll again
for that.
Okay, I will bring in Dr. Barnali at this point of time. With such patients, over time, what I've realized is that the most important thing here is history. And if not history, then it is history. And if still not history, then again it is history. Because on examination, you will get 2-3 findings. But this kind of history gives us analysis of over, say, 4 years. Examination will be a one-time assessment. It will not yield anything. So we if you have to hammer something out, it has to be on history. But one thing is for sure, that you are saying that there are no clear features of CHF, and the child continues to have fast breathing also in between. So it boils down to the fact that there is something going on in the lungs. So the rest of the points that we need to ask on history, and you would see in the chat box also, are to look at what are the causes for this kind of a pulmonary bleed. And you have to look for those things. So first of all, I will involve Dr. Varnali Bhattacharya. Ma'am, anything else other than these differentials?
No, again, as you brought out, Kamal, is that absolutely, yes, it's an ongoing blood loss because she's needing these repeated transfusion. And in the history, the only thing that's popping up repeatedly are the respiratory. So we've kind of zeroed down now to something that's happening in the lung, and also breathlessness without cough. That is also and though she is nebulized on and off, I also want to know that did she have any dramatic response in her breathlessness to nebulization? So if there is no dramatic response to her breathlessness with these nebulizations, which would be generally, bronchodilators, then we've knocked off. We are kind of zeroing down more into probably some restrictive disease, which is giving breathlessness. Then we have to think that what is that restrictive lung disease? So I would then ask her, go back to, are there any other renal symptoms, which she has already negated. So, I kind of, with the history of cough, rare, breathlessness more, bleeding ongoing, nebulization, but there is no remark on is there any dramatic response to it. So I would think that there is some bleed happening in the lungs and probably focus on that.
Thank you, ma'am. Dr. Rashmi.
Yeah, so from the history, it's quite evident that the child is having recurrent blood loss somewhere, right? In between, although the child is having breathlessness, so the symptoms are there, but there is bleed somewhere, and if the child's growth is fine. So when the blood transfusions are given, the child is generally growing well and eating well. There has been no complaints regarding this. So what I feel is that the diagnosis AV malformation should come a little lower, and the celiac disease uh, and one more diagnosis as Heiner's disease. Well, you have written pulmonary hemorrhage should come before, like 1, 2, and third should be the AV malformation. These three are, according to me, the most likely diagnosis, what from the history which comes out.
Thank you, madam. So what we would do now is we will proceed with the examination, and once she is done with the examination, we'll again have a look at this, and we will discuss these celiac and Heiner business and the response to nebulization. We'll have a look at it again. So, Dr. Vinila, please proceed with your examination.
Yes, sir. General physical examination of the child. She's a young girl sitting comfortably on the bed with no signs of distress. This is a clinical picture. I've taken it with consent of the parents. Vital signs of the child. Her pulse rates are 94 beats per minute, where rhythm, character, volume are all normal. Her respiratory rate is 28 breaths per minute. They're regular. Blood pressure measured is 104 by 66 millimeters of mercury, which falls between 50th to 90th centile for her. Temperature was normal. Saturations were measured to be 96% at room air. All peripheral pulses were well felt. And her anthropometry, her weight is 16.9 kilograms, which falls between 10th to 25th centile. Her height is 111 centimeters, which falls between 50th to 75th centile. Her BMI is 14.8, which is falling between 15th to 50th centile. Her growth is fairly normal. Head-to-toe examination, the positive findings here is pallor seen, pallor is present. She has poor dental hygiene. Then there's a swelling noted below the mammary area on the left side, measuring approximately 5 into 7 centimeters. Others, head-to-toe is fairly normal. Examination of swelling. The size of the swelling is 5 into 7 centimeters on the anterior chest wall, left side below the nipple region. On palpation, there's no local rise of temperature or tenderness. Swelling size is 5 into 7 centimeters, extending over the 7th to the 10th anterior ribs, extending medially from the lateral border of the sternum and laterally to the anterior axillary line. The margins of the swelling are rounded and regular. The swelling is mobile and soft in consistency, and skin over the swelling is pinchable. With this examination, the closest diagnosis is a lipoma. Examination of per abdomen. On inspection, abdomen is scaphoid in shape. There's no visible distension or peristalsis. No scars or pulsation seen. Umbilicus is centrally placed, inverted and normal in appearance. Swelling is seen in the left hypochondriac region. Respiratory movements are present and normal. On palpation, abdomen is soft and non-tender. There's no guarding or rigidity. Liver is palpable 1 centimeter below the right costal margin. Liver span measured is 8 centimeters, which is normal for age. Spleen is not palpable. On auscultation, bowel sounds are heard normally. Examination of the respiratory system. Upper respiratory system is examined to be normal. Lower respiratory system on inspection. Shape of the chest is symmetrical. Swelling is seen present on the left side of the chest. Chest walls are normally. Chest wall movements are normal. Trachea is central. Apical impulse is seen on the 5th intercostal space, lateral to the midclavicular line. There's no deformities of the chest wall, and back of the chest is also normal. On palpation, trachea is central. Apical impulse position is confirmed on palpation. Chest expansion is symmetrical, and there's no other palpable findings. On percussion, all the areas of percussion are resonant. There is no finding otherwise. On auscultation, breath sounds are heard normal. Normal vestibular breath sounds are heard in all regions of auscultation, and there are no added sounds. Other system examination is within normal limits. On cardiovascular examination, there's a systolic murmur heard. CNS is normal. The summary points are this child is a case of refractory pneumonia. Growth is normal. There's no respiratory findings, and there is a lipoma.
Okay. Thank you, Dr. Vanilla. So now we have few things which have come up with this. So, you know, I'll call in the lead discussants first. Dr. Rashmi, anything that you wish to bring out here with this examination and ask the presenter?
I just wanted to know, did you hear some bruit over lipoma? Because you haven't done any examination, like any investigation of lipoma, like ultrasound, etc. And we are making a diagnosis before that. So could you hear the bruit over the mass?
No, ma'am.
And how long has the mass been there?
It's been there for about 7 to 8 months, ma'am, but the growth has been only in the last 4 months.
It's started increasing suddenly.
No, ma'am, it was a very gradual progression.
So it wasn't there until the age of 1 to 2 years. That means it
was
just
not
started
there until the age of almost 4 years, ma'am.
not there, and it suddenly appeared and it started growing gradually only very recently.
Yes, ma'am.
Right? And there was no bruit heard over this swelling.
No, ma'am.
And there was no other this kind of a swelling anywhere in the body.
No, ma'am. This was the only swelling, ma'am.
Okay. So I feel that we would get a clue after getting an ultrasound done of this, and I still feel that this is recurrent, sounds like recurrent now after your examination and history, sounds like a recurrent pulmonary hemorrhage, recurrent hemorrhage in the lungs, parenchyma or whatever, wherever, we don't know right now, and which is leading to refractory anemia. This is as of now we can reach this conclusion.
Yes.
Thank you, Dr. Rashmi, ma'am. Dr. Banali.
I think the growth that you've mentioned is a very important thing that, she presented at 1.5 months and has kind of held on to a normal growth, meaning, all those malabsorption, all that we can let go. And but there is some acute burst of things happening, which is dropping her HB, because that easy fatigability is anemia, and I don't agree with easy fatigability and breathlessness doesn't become synonymous. So there is anemia and there is something in the lung in a kid who's growing normally. So I kind of again zero down to, idiopathic pulmonary hemorrhage?
So I agree with Dr. Banali because Dr. Vanilla, there are three things. If they are there, you in children, you can say the IPH or idiopathic pulmonary hemorrhage. Idiopathic because after all this questioning and probing, we still do not have a reason for this pulmonary bleed. That's why we are saying idiopathic till now. With the rest of the investigation that you present, it may become pulmonary hemocirrhosis for which we have a cause. Till now, it is still idiopathic with all your history and examination. If a child has anemia, which is refractory to whatever doing, if the child has radiological shadows, which is clear in your history, that if somebody has been reporting them as pneumonias, he has shadows, he has anemia which is persisting, and even without hemoptysis, if he simply has persistent anemia and fast breathing or distress, this triad in pediatrics is good enough to label somebody as having pulmonary hemocirrhosis. So we do not doubt as of now pulmonary hemocirrhosis. The only thing is what else. So if you look at the your anthro, we know he's growing well. There are 2-3 things which for which, like as we said, high nurse, on your history, probably history of any ear discharges or cow milk initially, that could give you a clue, but then it has to be some ear discharge or something. For celiac, I would say it is very, very important to ask that question, how many times per day she is passing stools, because it's a treatable cause of pulmonary hemocirrhosis if celiac is resulting in this. And there are case reports where they say, okay, you may not, the child may not be I mean, the child will be anthropometrically relatively normal even when he has celiac in this early stage, and he can still have pulmonary hemocirrhosis. So there are reported cases. I reported a series of 3 in which 2 did not have any significant GI symptoms or this abnormal anthro. So we have to probe that. But I think IPH is one. 2-3 things that have come up is that you are saying that there is some murmur that needs to be answered as of now. I think how severe, what is the hemic murmur or something else that we would want to see clarification from you. Other than this one, first of all, let us ask this. Dr. Vanilla, what do you think this murmur is?
If the child has presented to us in severe pneumonia, it could be a hemic murmur, which is usually heard as an ejection systolic murmur.
No, we are not talking about textbook. In your child, does it look like hemic or does it look like something else?
Yes, sir, it looked like hemic murmur.
Second issue was that this mass or lump which you are saying, if you have not heard any bruit with your examination, I think fluctuation and transillumination, every thing would have been done. Based on that, you feel it is lipoma. And there was no bruit.
There was no bruit, sir, and the color over the swelling was normal. Skin was normal.
Okay, perfect. I think let's proceed with the investigations.
Okay,
Because
sir.
in terms of thought process, this is all that one could have done. If a child has such kind of anemias, recurrent distress, X-ray showing some kind of a pneumonia, pulmonary hemocirrhosis should be thought of. And then we should look at all the causes that can be there. Because it does not have any generalized bleed, less likely to be a systemic bleeding presenting as pulmonary hair. It is something specific to lungs. It is started so early. It is something genetic or congenital. It could be celiac resulting in this. So this is how you approach such a case. So let's proceed with the examination, with the investigations.
Okay, sir. These are the serial investigations available from the past admissions, where at 1.5 months of age, hemoglobin was 9.9 gram per deciliter. Total count was normal, 8,780, with a differential of neutrophils 46 and lymphocytes of 38%. Platelet count was normal. RBC count is 3.2 million per mmQ. MCV is 86, MCH is 31.4, MCHC is 36.5, and RDW is 16%. All the RBC indices are normal for age at that point. Peripheral smear was suggestive of a microcytic hypochromic anemia. At 4 years, 6 months, hemoglobin was, when there was a first admission for generalized weakness and pallor,
So,
Hemoglobin.
sorry, Dr. Vanilla, sorry to interrupt you. I think whatever we are showing is that some anemia which was going down and with transfusion it came up. This is what we
Yes.
have. And whatever you presented on day one, this is more or less the hematological picture. Microcytic hypochromic anemia with an isopoikilocytosis and
Yes.
fluctuating hemoglobin levels, which are improved with transfusions.
Yes.
So we can go on to the next, which will save on some time. Sorry.
Okay. So it was evaluated at all these settings further, where Menzer index was always more than 13, which is indicative of iron deficiency anemia only. Retic count was normal. Direct Coombs test was negative. Coagulation tests were normal. Stool for occult blood was done, which was negative. HP electrophoresis was also done, which was reported normal. Thyroid testing was done for easy fatigability as the presenting symptom, which was normal. There was an autoimmune panel done as well, which was negative. Hepcidin levels were low normal and transferrin levels were also normal. These are the findings at one screenshot of this iron studies where serum ferritin is 125, which is fairly normal, but the iron was significantly low at 13. TIBC is again within the normal range, and transferrin receptor saturation is very low. Bone marrow aspirate report is also available, which was showing a normal cellular marrow for age with good cell trails. All the erythropoiesis and myelopoiesis, all stages of maturations were seen here, which rules out our bone marrow suppression. And the impression that was given was features that were persistent with iron deficiency anemia. Furthermore, RBC scintigraphy testing was done where they saw a little distal ileum bleed, but then the child was subjected further to MR enterography, which was reported normal. Stool for occult blood was again negative. A 2D echo was done at 4 years, 8 months of age, which was then reported normal. These are the serial chest radiographs that we have of this child before the current presentation. I'll be projecting all three. The first X-ray is at 1 year, 5 months of age. The second is at 4 years, 7 months of age, and the third is at 5 years of age. The first X-ray is an AP view of the chest where the lung shadows, there is some amount of hyperinflation seen on this X-ray. On the second one, at 4 years, 7 months, there is some heterogeneous opacity seen in the middle and lower zones, which was then attributed to pneumonia and treated. At 5 years of age, there is some clear infiltration seen on both sides at the middle and lower zones, where the lung appears more whiter in the lower parts than the upper zone.
Okay, Dr. Vanilla, let's hold on to that slide.
Yes.
Dr. Rashmi, any comments on this? Anything that you see different?
Yeah, the first X-ray is actually very rotated, and there is a significant hyperinflation in the first X-ray that we see. And yeah, in the first X-ray, I just can see that there is on the left side, left upper lobe, there could be a homogeneous opacity with small, cystic things, hypolucent areas in the left upper lobe. Can you just, yeah, this one. So this one is scapula, but this is the region which one could consider as resolving or an evolving consolidation on the left side. And in the second X-ray, we can see the nodular opacities are seen in both the lungs. It is present; they are present all over the lung. There is no volume loss, and we can see that the opacities are more on the lower side, lower zone, than in the upper zone. And they are bilaterally diffused. in the third X-ray, there is see, looks like right cardiac silhouette is not very clearly visible, or I could feel that the pulmonary vessels are quite enlarged, and it's difficult to actually no, right heart border is clear, but yeah, these are the vessels which are where one can see they are prominent bronchovascular markings. Um and we do not see those shadows which were present in the second X-ray over here, those nodular opacities in the third X-ray.
Thank you, Dr. Rashmi ma'am. Dr.
Yeah.
Banali ma'am.
So in the first, but for hyperinflation and the one thing on top on the left lung, I don't find it any grossly abnormal. It's the second X-ray where I see a lot of opacities predominantly in the base. And with what we are thinking, a possibility this kind of goes more in favor. At 5 years, there is a generalized haziness. It's not a normal looking lung. And so definitely it's ongoing. And the 4 year, 7 months does show a lot of kind of, whether you call it reticular or in the lower down, it's more fluffy. And the 5 year one, there is a generalized haziness.
Yes. So other than that, what I feel, the first one had definitely hyperinflation, but the heart size is as if progressively increasing. What I see from the first X-ray onwards, the second time it looks larger, the third time it looks even larger. So either it is the X-ray was so timed that the child is in failure at that time and we got it done. Otherwise, what I would say is that something is going on progressively. And if you look at the opacities also in the first radiograph, it is only hyperinflation, but lung, apart from that localized involvement in the upper zones, the lower and the middle zones are relatively clear. But later on, they are becoming more and more dense, as if the ground glassing is becoming more and more dense. Interestingly, the pulmonary artery is still not prominent. With this kind of a presentation, if suppose somebody is having chronic hypoxia and such things, chronic anemia, then cardiomegaly, if suppose is progressively going on, then pulmonary artery may also become prominent, which is still not there. So definitely ground glassing is coming up and progressively increasing. So Vinila, I think we everybody here knows that the child is bleeding in lungs. There is pulmonary hemosiderosis, and for those if there are residents in audience, this is one of the things where you say, na, all miliary or not TB. If this second X-ray or third X-ray comes to you in isolation, you may think that, okay, this is miliary, this is likely to be TB. So there are other causes for reticulonodular shadows, which on radiograph can be very difficult to differentiate. So think broader. Hemosiderosis is one such conditions where you can have diffuse lung involvement with such kind of fine shadows which can mimic miliary. So this was on, I think, a radiograph that we had. Okay, Dr. Vanila, please proceed.
Yes. So until now, we have presented investigations from the past, and these are the investigations at what we did at this screenshot. Hemoglobin was again 5.6 gram per deciliter, and all the indices are pointing towards the same picture as previously. ESR was normal. The peripheral smear was again microcytic hypochromic with anisopoikilocytosis with teardrop cells and elliptocytes, and eosinophilia was also noted. The absolute eosinophil count was 670. ANC, ALC, and absolute monocyte count were as presented. The serum iron testing, iron binding capacities, and all were again subjected, which were all indicative towards the same picture as previously. Stool for occult blood was again done, which was negative. Stool for ova and cyst was also analyzed, which was negative. Total IgA levels and TTG IgA antibodies were done to rule out celiac diseases, which were negative for celiac. This is the chest X-ray at this presentation. where a child had no complaints of cough and no respiratory findings as well. But this is the radiographical presentation, where we can see diffuse opacities bilaterally in the middle and lower zones. The CT ratio here is was calculated. It is coming to 55%, which is
How much was in those previous X-rays? Third
the
one.
previous. Actually, it was a little amount of rotation, sir, but it had shown 60% at 5 years of age, the last one.
Yes, because it looks 60%.
Yes.
So rotation
But
alone
then
do not change CT ratio that much. But
yes,
fine.
that echo was done and they had reported normal, so they hadn't followed up after that. We had got it done at this admission. Sir.
Dr. Banali, do you feel that the density is getting denser as we are progressing?
Yes, definitely. Like now, it's just not the lower, the middle zone is also, so both sides. But for the upper region, everything is kind of now, you know.
Yes. Dr. Rashmi.
Yeah, there are bilateral diffuse opacities seen more in the middle and the lower zone on both the sides. I think they are sparing the apex. What I can see from the X-ray, very few.
Yes. Okay, Dr. Vinila, let's proceed.
Yes. This was the CT done of the chest. This is the lung window of axial view. There, we do see a lot of ground glassing opacities with septal thickenings observed and some amount of micronodularity also seen. We can also make out some swelling in the subcutaneous plane, which probably is again talking to us about the swelling lower down.
So my question to you, Dr. Vinila, would be how much was the fibrosis? Because these images we cannot comment. It's not visible to us. So how much is the fibrosis? Did you ask this question to the radiologist? I think we have a radiologist on board today. So we'll keep this for him. The question is parked, because if somebody is having such kind of bleeds over time progressively, the fibrosis sets in. And once the fibrosis sets in, it's a non-reversible kind of a thing. If it is just bleed, the lungs will clear in between completely. But if you saw the densities are progressively increasing by the time, probably it is fibrosis which is setting in, which is not a good sign. Over time, that fibrosis is not easy to reverse. So whatever be the cause of the bleed, this fibrosis is going to create problems. We'll ask that with the radiologist, your mentor that we have. And another thing is, in a mediastinal window, you could have commented on that pulmonary artery here also. So in your report, any comment on the pulmonary artery?
No, sir.
Okay, fine. We will ask Dr. Saurabh. Yes, please proceed.
A flexible bronchoscopy was done, which showed a normal airway anatomy. BAL sampling was done for the same. The bronchoalveolar lavage findings showed hemosiderin laden macrophages of 99%. BAL fluid analysis was also subjected for tuberculosis, which was negative at workup. But the culture showed methicillin-resistant Staphylococcus aureus, which was isolated in the fluid. Immune workup was also done for this child. ANCA, ANA global was sent, immunoprofile was sent, 1 Willebrand factor, APLA, myeloperoxidase, and protein reactase 3 were also done. All of these were reported negative. A 2D echo was done because there was some cardiac shadows which we were not okay with. There was a small apical muscular VSD with the left to right shunting. Other than that, PA pressures were normal of 25 millimeters per mm of Hg. With good biventricular function and normal sized chambers, and it was a cytosolitis and levocardia. We did an impulse oscillometry in this child as well. We can see that the R5 in this child was fairly normal. And the small airway resistance index was calculated and it was increased. And there is significant bronchodilator response seen in R5 and I can't see this. R5 and EX. Yeah. R5, which do suggest that it could go towards asthma. My final diagnosis is idiopathic pulmonary hemosiderosis, as this is a diagnosis of exclusion. We have worked up, we have come to this conclusion after negating all the other possibilities. Bowel culture showed MRSA growth. The second diagnosis is lipoma of the left anterior chest wall, which is progressing and requires some attention. Third diagnosis is asthma based on history of nebulizations in the past. And now the IOS is showing significant bronchodilator response. And the fourth diagnosis here is a small apical muscular VSD.
Thank you, Dr. Vanilla. Thank you so much. Your slides were very, very good, very well-made presentation, very well presented with confidence. And we wish you very best of luck for the rest of your career also. I think we have had a very nice discussion. Now, let's have 2-3 things which have come up now. I think there are two noises which we have seen here. One is probably that lipoma, which and this MRSA. In our practice, normally, if this MRSA thing is not fitting into our overall clinical scenario, I would not probably even treat if it is not facing that. So do you think this MRSA was something related to your patient, or incidentally, you can have these contaminations from the lab also if at times. So you have to clinically correlate.
Definitely, sir. We do see a lot of crossover with organisms that happen with bronchoalveolar lavage. This specific child didn't have any symptoms suggestive of an infection. So,
okay, fine. Another thing is, this asthma, there was a question asked, what is the response to nebulization in this child? When a child bleeds in lungs, it irritates the airway. So it behaves more like an asthma. Asthma is a reaction of the airway to some irritant. Here, the irritant is blood. It is, in that sense, phenotypically, it will behave like an asthma, but this is not an asthma. Everything, if a cystic fibrosis patient develops infection, he will come to you with wheeze. Similarly, an IPH, when he bleeds, he comes to you with wheeze. So we will not label it as asthma. It's an exacerbation of CF. It's an exacerbation of IPH. So the PFT that you showed, the IOS, that only tells you that there is the airways are hyperreacting and they're responding to bronchodilator. So the asthma would not fit in here. It is an exacerbation of IPH only. Dr. Barnali, would you have done a CT or a bronchoscopy first?
In a situation like this, I would, since we were still groping, I would do a CT and then, if directed, would do the bronchoscopy. Because
we'll do a CT first.
Yes. But,
okay.
And I also want to comment on that FOT that Vanilla showed, is that if we are thinking of fibrosis, and yes, we know that, this bronchodilator, the reversibility is also not so significant. It doesn't fit into the cutoff values. But, we have something called the X5 inspiratory and the X5 expiratory. If it's restrictive, the X5 inspiratory would be significantly more negative. So I just want to ask Vanilla, since it's Dr. Kalpanavar's,
yes,
thing that he would have probably done the X5 inspiratory. Does that show anything? Is it more negative than the expiratory?
This was not done on Antilia Pro, so we don't have the inspiratory, expiratory values of X5 in this.
Because otherwise you have an X5 inspiratory,
yes,
which is more negative if you're thinking of a restrictive.
Yes.
Actually, Antilla Pro gives that, but anyway, nevertheless.
We didn't do it on the Antilia.
You didn't do it.
So
Dr. Kamal, you were asking me something else. Yes.
So this would be now I'll bring in the mentor with those final burning questions.
So I just
yes,
can
Dr.
I
Rashmi.
just
Yes,
So
please, ma'am.
whatever I could see on the CT, I could find no fibrosis there. And so this child would not have shown any restrictive lung disease as of now. Whatever little was visible on the CT, I don't know what was the report of the CT. And the way the child presented, typically it is the first thing that comes to your mind is a pulmonary hemorrhage, recurrent pulmonary hemorrhage. And we see a lot of idiopathic pulmonary hemosiderosis. So from my side, if this was the history, I would have done bronchoscopy first, because that would have we would have anyway done bronchoscopy to confirm the diagnosis, to do the BAL, to find out the hemosidrin laden macrophages, which is the gold standard to confirm the diagnosis of idiopathic pulmonary hemosiderosis.
Thank you so
So
much,
that
ma'am.
was my bit.
Thank you so much. So from my take, I think we should do both, because they both serve different purposes. Bronchoscopy, if suppose he has not bled at that time, bronchoscopy may be normal. Like in this child, airway was normal. And if suppose he has not bled recently, bronchoscopic lavage would also be normal. CT is telling you things like fibrosis and rest of the things also. So both are needed based on what is available to you and what is convenient to you. You will do whatever first. But if you are suspecting pulmonary bleed, X-ray doesn't give you lead, CT is something that comes up. Now I will bring Dr. Saurabh. Dr. Saurabh, are you there?
Yes, sir. Good evening, sir.
Good evening. So, and now I'm putting you three things. You have a VSD which did not sound like VSD, but later on it became VSD, which was causing PH. And we know when you have a pulmonary artery hypertension by 5 years of age, if suppose she is going into Eisenmangration and all, you can have bleed because of that also. So based on what your radiological assessment, what do you think the CT and all suggested?
Yeah. So, sir, first off, regarding this thing, that the VSD was small in size, not significant enough to
sorry
cause...
to interrupt you. Small VSD has a harsh murmur. If the VSD is large, it will have a soft blowing murmur which you can miss.
Sir.
It will have manifestation, but a small VSD gives such a harsh murmur, it is very difficult to miss.
So that is why it was not in classical type murmur, but actually when we was the hemi,
your voice is cracking. Maybe you can switch off your video. Probably that will improve the voice quality.
So,
yes.
Second thing, before this case was presented, it was actually
your voice is still cracking. We can't hear it. We can't hear you.
Maybe you can stop your video.
He has lost connection.
Okay, I think we have already gone over time. I wanted to have his opinion because he is a trained radiologist. He would have guided us on the CT scan. I think I have had a very good 1 hour where I could dissect this case. We knew from the presenting complaint itself that it is pulmonary hemosiderosis. It was just about not the destination, it was the journey that we wanted to have. So from the first slide, we knew it is pulmonary hemosiderosis, but we had to get each and everything the way you would approach the next time you have a case of pulmonary hemosiderosis. So I sincerely thank Dr. Barnali, Dr. Rashmi Kapoor for making this academic exercise very, very interesting. So thank you, Dr. Vinila, for an excellent presentation. Over to Dr. Rawat, sir. Thank you from my side.
Okay, so thank you very much, Dr. Vinila, for an excellent case. You have presented the case exactly in the way a student should present in the exam, because you have covered almost all the points and you have covered in very much detail. So I think it is absolutely fine. The viewers must have learned how to ideally present a case in almost minutest details. I think this is what examiner they want. The first thing is that. Second thing is that what Dr. Singhal is telling, that the destination is not important. The route which you have taken is important. So you might be knowing the destination, that diagnosis is this, but if you falter at the process in which you reach the diagnosis, then probably you have not done a good job. So the aim of this session was to unravel the journey. How do you progress and how do you attain, how do you reach to the diagnosis, ruling out all the possible causes. So I think you did an excellent job on guiding us how to go ahead in this particular journey. And third very important point, which we got, is that not all systemic diseases, they will present with obvious pulmonary symptoms. Like, for example, a child with recurrent pulmonary hemorrhage, he might not have very obvious respiratory symptom. He might come you with anemia, failure to thrive, all those things. So again, keeping a broad outlook, thinking out of the box, seeing a child with chronic anemia, and definitely you must think that with even slightest respiratory symptom like difficulty in breathing or requiring oxygen sometime or cough sometime, you must think that probably it could be some pulmonary cause. So pulmonary diseases may not present with obvious pulmonary symptom, and it could have some chronic things like anemia. So your kids has given some very important learning points. Thank you very much. I thank Dr. Singhal for an excellent moderation of the case, bringing out very small, minute point which were very useful to all the people who watch. And I'll thank Dr. Barnali and Dr. Raji Kapoor for an excellent moderation of the case. They have given very some leading thoughts for to unravel the mystery, and everything went well. So thank you very much. So we'll close this session today. Yes.
Dr. Saurav, if he is there, maybe you can have the last word from him.
Sir, sorry. Yeah.
Yes,
sir,
please.
Sorry. So the reason why this child, I mean, we after listening to the history in the pulmonology forum, most of you are very clear that this is a classical pulmonary hemorrhage which is going on. But what happens in the reality in the that is not it is usually the thing which is the lungs which are missed. So like the especially practitioners like where these children are the primary first point of contact. Like when this child was, and any child bleeds, please interrogate a bit deeply into whether there are any other respiratory symptoms, cough or breathlessness, which is significant. So even we have seen many times X-rays were done, but they were just treated like pneumonia or with some bronchodilators, but nothing beyond action was taken, and the child continued to. So that is the important thing, that to consider lungs also in the DD of refractory iron deficiency anemia or recurrent microcytic hypochromic anemia. Like in this, what else was not done except the the bronchoscopy and BAL, like in the Meckel scan, this and that scan, tool things were done. Look into the lungs also when a child has a refractory anemia. MRSA thing which was not with power 4. So it was 10 power 3 and the child was completely asymptomatic. But we did treat that because we had to start steroids after that. So because of that, and at the same time, the the other family members were also treated with mupirocin.
Thank you, Dr.
And other thing was the child was the child was not being treated for a long time. There were areas of fibrosis. The other all CT images were not displayed. So there are, so because this child has been bleeding for a long.
Yes,
and
this.
No.
So
thank you,
Dr. Jain, for the comment. In the last, I'd like to congratulate Dr. Kalabnavar, under whom this girl is doing her PG, and the amount of training which she has given to this resident, I think it is phenomenal. The way she has presented the case and the clarity of her thought, I think Dr. Kalabnavar deserves a good accolade for an excellent training which is given to the resident. Thank you very, very much. So we come to the end of this session today, and we'll again meet next month, last Monday, where we'll again unravel another mystery of a child with pulmonary symptoms. Thank you very much. Good night and goodbye from IPNRC.
Good night.
Thank you so much.
Thank you.
Thank you, Kamal.
Thank you, ma'am.
Thank you. Good night, sir. Good night. Thank you.
Bye.
Thank you.